Oh, thank you. The honor is mine, and I appreciate the invitation to your Congress, which looks like it's going to be a marvelous event. On behalf of the American College of Cardiology, thank you for the invitation, for being our incredible partner throughout Brazil in that global fight against heart disease. And Dr. Ramires could not have teed up my talk any better because I think the challenges of research are well known, and the implementation of the guidelines that our physician colleagues do is so incredibly important. So that's the topic of my speech. As the first non-physician president of the college, it is so important to utilize our team. And I was thrilled when Mary Christina mentioned that your team is here. Your pharmacists, your palliative care, your nurses are also very important in the care of our patients, especially as relates to heart disease, because there's no doubt that, as we've heard, our guidelines are not perfect yet. It would be ideal if we could have all 1A guidelines, but we don't. So hopefully through our time today together, and I will try to talk slowly, but I am from Chicago, so I tend to speak a little bit fast. My day job is with 110 cardiologists in the city of Chicago, and we have 14 acute care hospitals. So heart failure has been something that we have been struggling with for quite a long time, as well as the leadership of our heart failure clinic. So actually, I'm going to start this talk a little bit differently outside of that clinical realm because of the incredible need for dyad leadership. And then we'll talk about guideline-directed medical therapy through the CV team. So a little bit about dyad leadership. If you've never heard of dyad leadership, it's something that I have been practicing for a very long time. I'm a little bit older than most of you. I'm thrilled to see so many of our younger physician colleagues. And this is something I would strongly encourage. When I was in Puerto Alegre last year, we talked a lot about cardiovascular service lines. And dyad leaderships are our physicians and our administrators working together, because you've heard a little bit already in this Congress about how important economics and quality is to delivering cardiovascular care throughout Brazil as well as throughout the globe. And my style of leadership, I was a nurse, I'm a very old nurse, but the thing that I think has made our team successful is I've worked with my physician colleague for almost 30 years. And so we can start to finish each other's thoughts, because he is so skilled in the clinical world, and I help the financial sustainability, the quality metrics, the patient-reported outcomes, those critical elements that are so important. And so having that type of a team together, because the corporate practice of healthcare throughout the globe is a very real thing. And the reality is we need two things to practice medicine. We need a patient and we need a physician. And so it is imperative on us, as we have so many patients entering the system as we get older and older, and our patients become more and more in need of cardiovascular care, it's imperative that we have a team help them. And it's also imperative that we have those with the right skill sets. I do not expect my physicians to understand balance sheets and return on investment and all those types of things that your health minister and other administrative people need. But in your hospitals, in your academic centers, in your private hospitals, we need to make sure that we have medicine in a sustainable role. You just heard about the drugs. You heard about the change in guideline-directed medical therapy and how critical medical therapy is, specifically in heart failure, and how expensive it is. And so no matter what you prescribe, I have to make sure our patients will take it and can pay for it and will sustain it. All of those become very, very important elements, because you just diagnosing and prescribing is not going to get us to the end of really solving this global burden of heart disease. So ensuring that our physicians set those standards of quality of care and ensuring that our administrative people are there to help is becoming very, very important. That synergistic approach becomes important because we learn each other's roles. Just like we need our pharmacists, we desperately need our pharmacists in our heart failure clinics. We need our dietitians, and we really need our palliative care people, because when our patients get to that part of life where their quality of life is not what they necessarily want, how do we help them transition to that next part of their journey with heart failure? And so that entire team approach becomes really important, including our social workers that help with different sites of care as to where our patients are going to go. And that communication is so important. You also heard from Dr. Morris how important it is. Our patients come into our system in 1,000 different ways. Even in Brazil, I was hearing about some of your more outlying areas. So you have your little hospitals, not your big tertiary care centers. We have our clinics. We have our emergency rooms. We have lots of different ways that our patients enter our healthcare system, and communicating our guidelines becomes so very important. Why am I such a champion of dyad leadership? Because if we stay in our silos, if we stay with our physicians just staying in the clinical world, and our administrative team in Chicago, they all live on the 8th floor. So I always call it the 8th floor. I don't know where they live in Brazil, but they tend to live in that 8th floor in Chicago. So whatever that 8th floor is doing does impact how we take care of our patients. So by making sure that in the boardroom, in the Ministry of Health, in Congress, you heard about our Brazilian Society working on advocacy, because it's so very important for our patients and what you do in the field every single day. So the evolving landscape globally of the shortage of physicians is very real. The issue is that we have so many physicians, so many patients, and not enough physicians to take care for them. How can you possibly see as many patients that need your services? So we are expecting a shortage of physicians in the United States alone of about 40,000. So knowing that, we know that we have to deliver care in a totally different way. Some of our talks throughout the Congress will talk about that transformation of care, because we cannot continue to deliver care. And learning from each other, the different ways of doing it becomes so very, very important, because our population is going to continue to grow. Our baby boomers, as we call them in the United States, get older and older every single year, and they live longer and longer. And I know you don't do this in Brazil, but in the United States, they all go to McDonald's for breakfast, and then they go to Taco Bell for lunch, and then they can't figure out why they're in heart failure by the time dinner rolls around. So we do need to figure this out on how to make sure our patients become part of that process. So the very first part of doing guideline-directed medical therapy through a team approach is really understanding health equity and access. I think the pandemic taught us a lot. I think we unlearned it pretty quickly, but we have to bring it back, because we've seen it in our research trials. You just heard about it in our research trial, the lack of women, the lack of non-white males, the lack of our underrepresented minorities are so very important in research, because everybody evolves differently in the kind of care that they need. So I like to use this graphic, if you haven't seen it before, because it really identifies equally, equitably, and then what we really need to do. So you see the first one, the kids all sit on the exact same box. When I first showed this slide at the conference at ACC, the next ACC conference, there was a little box behind the podium so the short women could stand up, and everybody thought that was a really great progress and equality. Well, it really didn't do anything, because you can still see the little kid still has to peek through the slats. In the second one, you can see they added, so the little kid could see over the barrier. So they keep trying to change the system so everybody can see the ball game. But what really needs to happen? The last picture tells us what really needs to happen, and that's to get the barriers down. Same thing in healthcare. We have to get the barriers down. What is preventing our patients from coming into our offices early on in the need for their treatment of heart disease? So it's up to us to take those barriers down. You've probably seen this slide. This has become my favorite slide of all time, the social determinants of health, because as I told you, I'm an old nurse, and I used to think what we did was really, 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 really important. And what we did changed the lives of our patients. And then I realized that I had my patients for about 15 minutes, maybe a half hour. And what I could impart to them in that half hour, in reality, only changed their outcome by 20%. So I'm thinking to myself, what in the world am I doing? Because I had no clue what their social determinants were. I had no clue where they lived. I had no clue what kind of money they made. I had no clue whether they knew about tobacco cessation or even how to take their blood pressure. I had no clue what their community was like. And I could have been talking English and they could have been Portuguese and didn't understand a word I said. So our healthcare team must deliver personalized care for that patient. We need people who look like our patients, who understand their cultures, because 80% of their outcome is determined by those social determinants of health. It is something we must embed in every one of our clinics from here on out. And as you also heard, we must get the patient back in the middle. Now, I will say with this graphic, I debated with the team long and hard, because I wanted the patient on that journey with us. I wanted them living this journey with us. And then I thought, no, not really. That patient needs to be right in the center. So this is an ACC diagram. It also highlights the critical importance of AI. We're going to talk through the Congress about AI and how we need to use artificial intelligence to help us, not to replace us, but to utilize the tools that are there for us to take care of our patients as they go through that, and to understand every single step that impacts whether or not they take their drugs, in spite of whether we prescribe them or not, and what their diet is like, what their exercise is like, all those other elements. So we're going to go kind of quickly through how we design it. We try to not say heart failure anymore. It's been a cultural change for us because it tended to scare our patients. I don't know if it scares your patients. When you tell them their heart is failing, they get all discombobulated. I don't know how that translates into Portuguese, but so we call it heart function. We say your heart isn't functioning optimally, so let's call it improving your heart function. And we have a care team that works using our nurses a lot for education and making sure we use our electronic health records or AI to ensure they're on all the guideline-directed medical therapy that is so very important to them. And the more important thing, and we'll talk about this a little bit later on this morning too, is that no matter where that patient enters our system, they are treated the same way with the same pathway. So 4 quick steps that you're more than welcome to take home and utilize. First put together a work group to decide what it is that you want to do. Make sure you know exactly how your patients are transitioning through your system, because every system is different. It has to have a business plan. Remember that dyad leadership we talked about a little bit, because we do have to have a business, a sustainable model that will work. And then we have to put it all together for our patients. Physician champion, critically important. They are our cheerleader. They're the ones that will convince the emergency room to do high-dose diuretics. They're the ones that will convince the primary care physicians on when to transfer the patients. So they become our leader and our champion. They also tend to be the ones we start with heart function clinics, and then we go to advanced heart function clinics, obviously ending in our VAD and transplant program, and obviously always staying patient-focused. So our heart care transition team is another example that we use. We use this for our pre-op clearances as well as for all of our discharges in order to keep patients out of the hospital. We like our MI and our heart failure patients to be seen within 48 hours. We're done with the 5 days. We're at 48 hours post-discharge. Why is that? Because they have no clue what you said to them in the hospital. They do not remember one word that you said about the white pill versus the blue pill versus the yellow pill. They just know that they got a whole bunch of pills and you said to take them. So we really need to make sure that we have got that medication reconciliation down pat so they understand what you told them. And that heart care treatment works really, really well. And it's an important clinic visit. We will go to the home on rare occasions, but we do try to get them. We do use telehealth, probably not as much as we should. But at least it's a way to touch and reach that patient to make sure they stay on that guideline-directed medical therapy. I just put a really quick staffing thing up there because the physicians, again, have to be supported. The physicians have to have their team so that they don't get so involved in one patient that they can't be doing what they need to do. So that's just a quick example of what our staffing looks like. And this is Sam. So Sam comes with me anywhere globally. He's one of my best friends because when I first met Sam, he came in with heart failure into our system in lots of different ways. He'd come in through the emergency room, they'd give him to a hospitalist, then they'd discharge him to a primary care, or maybe he did get to a cardiologist, but somehow he got to our structural cardiologist who just didn't want anything to do with him and wanted him to go over to our heart failure physician. So it was critical that we took it because Sam looked like this. He'd left the office and he really had no idea what he was doing or where he was supposed to go or what he was supposed to do. He did get a very lovely EMR printed instruction sheet that really made no sense to him whatsoever. So we had to unconfuse Sam. We had to make sure that he and his family knew exactly what to do and how to do it. And my best example of Sam was a Hispanic Sam whose wife came dutifully to every single meeting, met with a dietitian, met with the pharmacist, extremely compliant, came in the emergency room almost every single Monday in heart failure. And the wife's throwing up her arms. Sam's really upset because he can't figure it out until his wife said, you know what? You go see your mom every weekend because I don't like your mom. So you just go to see her and mom gives you everything you want for lunch. everything that is completely loaded with sodium, and you have a really good time with mom, and then you come home and you're in heart failure. So what did we need to do? We needed to bring mom in. And it is an entire family. So you really have to you have to take the time to understand what it is that your patients need. The other thing that we need to be very careful of is that where we provide care. Sao Paulo is a huge city. It's my first time here, but it is big. And how do you get your patients from here to there? That doesn't take an hour. Because I know coming from the airport took a really long time. So what do you do with your patients? Do you use telehealth? So we like to have clinics where the patients are. We don't bring them to the academic centers. We have little spaces throughout, and we go to the patients because where they get their care, and maybe Sao Paulo is a little bit different, but many of our patients are afraid of the hospitals. They pull up and there's just these massive, they have no idea where to park, no idea where to go, and they get very confused. So where we deliver that care is really important. How we build healthy communities is also very, very important. It's like an iceberg. We really need to make sure that we have a really firm ground and we work with our population health components. We work on preventative cardiology. We work on everybody knowing what their blood pressure is. That's the first step. It's great if they know what their lipid level is, but please, we've got to get them to know blood pressure, and that's the only way we're going to improve health and really treat heart disease. Innovation in AI is going to become so very important for all of us because it's the only way that we're going to be able to ensure equitable access to care. We have to make sure not only that our patients can get to us, but that we use shared decision-making to make sure that we treat their conditions in a way that works for them in the world that they're in. So I'm inviting all of my CV team members to join ACC to have access to all of our stuff. Obviously, and of my young fellows, we're hoping that you will join our fellowship program for our physicians and such. And so in the bottom kind of closing lines, what are my overall recommendations? Number one, make sure that you have a vision of where you're going. Make sure that you design your basic heart function and your advanced heart function clinics methodically and purposefully. Don't let them just evolve. Make sure that you have an endpoint in mind. Make sure that you align the heart failure clinic with overall goals because many of your patients will have multi-morbidities. So your diabetics, your hypertension. So our heart failure clinic is multimodality. We do have our surgeons in that because of our VAD program. We need to make sure that our heart failure clinic can support the patient population that we need. And then we need metrics. We need our quality outcomes, both our patient-reported quality outcomes, our readmission statuses, our diureses, all those types of things. And as AI continues to be more and more prevalent, how we're going to track all this monitoring. I call it the tsunami of data. We have lots of data coming from our patients, whether they're using CardioMEMS or interloop recorders. How do we get that data into a centralized location to ensure that we're monitoring it and making sure that we're using those tools appropriately? That's where AI can help us. And so with that, thank you so very much for the invitation. It's been my honor and privilege to be here with you, and I look forward to the rest of the conference. Thank you.